So let me introduce Professor Donita Africander. Donita currently leads the progestin and steroid receptor research group in the biochemistry department at Stellenbosch University. And for almost 20 years, she's been trying to understand the biological effects of progestins used in contraception and menopausal hormone therapy. Her interests are in understanding the side effects associated with progestins, such as an increased incidence of breast cancer and susceptibility to HIV. Donita and her team use cutting-edge molecular approaches to investigate the cellular mechanisms of different progestins by using model systems for immunity, breast cancer, obesity, and steroid biosynthesis. Donita has served as the senior editor for the Journal of Molecular Endocrinology and the Journal of Endocrinology. So, Donita, from a biochemical perspective, stress, just tell us a little bit what it does in the body if we talk about this too much stress and why it's important for women to understand this.
So, from a clinical perspective, there's a hormone called cortisol, and cortisol is the stress hormone. And yes, so you need cortisol for certain physiological processes, and cortisol is actually leads to anti-inflammatory responses. So we all know inflammation. But the problem is when you have this continued production of cortisol, you then get immunosuppressive effects. So people get ill more easily. Also, it affects the reproductive axis. Salome could be able to tell us. So yes, we need it for everyday activities, but too much of it can lead to even chronic inflammation, although it's thought to be mostly anti-inflammatory.
So chronic inflammation, I mean, that just sounds terrible. It sounds like hay fever. Okay, so let's just talk about that chronic inflammation and perhaps what happens in the body when we're inflamed. I mean, what happens?
I mean, chronic inflammation can lead to many different diseases, actually. So it is associated with the metabolic syndrome, so cardiovascular disease, increased risk of breast cancer, susceptibility to sexually transmitted diseases, a whole host of things that it can affect physiologically.
Right. So stress and too much stress and the type of stresses that we put ourselves under and how our lives are structured, that really matters for us. Renata, it's said that women and men deal with stress differently. So is that really true? How does that work?
Anita, first, the disclaimer again. I think whatever we say, there's always the risk of making a generalization. And not everyone is the same. Some men deal in the same way than the general woman, and some women deal in the same way than general men. And we're talking about the biological gender of people. So in general, again, the disclaimer, women tend to more internalize and more to maybe reach out to a friend. We will vent, we will seek support, or we will try harder, or we will become anxious, but we're also more prone to eventually seek professional help. Men tend, the generalization, to have more externalized behavior, a little bit of escapism into pornography or anger or substances. Though the substance thing definitely has shifted over the years, and what I see in clinical practice, an absolute rise in the incidence of substance abuse in women and also prescription drug abuse. So although there are differences, and the simplest way to summarize is internalizing versus externalizing behavior. I think when men are specifically at risk is they do not seek professional support. They want to deal with it themselves.
And that dealing with it then leads to finding these sort of crutches type of thing that may not be optimal. So in your article in the Women's Report, you refer to problem-focused ways of dealing with research versus emotion-focused ways. Can you just explain a little bit between the difference? Because maybe we can learn from that. So if women tend to be much more emotion focused and men problem focused in general, what can we learn from a problem focused way of dealing with?
So the simplest way of explaining that is you have a tough day at home, someone at work, someone upset you, you go home, you want to tell your husband about your day, and he jumps in and tell you, but you must do this, this, and this. Okay, that is the simplest way of summarizing it. You just wanted to hear, it's okay to be upset, I'm there for you, and he tell you immediately what you have to do. So that is the male way. They want to sort it, they want to fix it, and they often do. And we as women then feel like, but we will deal with it. We just need to know that we have support. But then it also tends to be that we do not solve the problem because we think we have to cope. We must just try harder. We must just get more support. And eventually the root cause of the problem remains often unaddressed, which then have secondary consequences again, like what we can have depersonalization, again, other type of negative behaviors, anxiety and depression, because why doesn't the problem get sorted, but we're not actually doing something about it?
Yeah. So it's just getting to that root, understanding a little bit more, and sometimes perhaps being, when he tells you, oh, do it like this, maybe listening a bit. But in that moment, it doesn't quite always feel like the appropriate response. I want to turn to Salome. Professor Salome Maswime is head of the Global Surgery Division at the University of Cape Town. She's an obstetrician and gynecologist, a member of the FIGO Committee on Ethical Aspects of Human Reproduction, a member of the United Nations Core Stillbirths Estimates Group, and chairperson of the Health Systems Trust Board. She's received numerous awards for her contribution to healthcare, including the Trailblazer and Young Achiever Award by the President of South Africa in 2017. And in 2023, she was a recipient of the NSFT SA Medical Research Council Clinical Scientist Award for pioneering global surgery in Africa. Salome, the issue of stillbirths, right? Just tell us a little bit more about that. I mean, how common is a stillbirth? And first, maybe what is a stillbirth? Let's just start with that definition.
Thank you so much. And thank you so much for inviting me, first of all, and for inviting me to be part of the book, of the chapter that I contributed to. So a stillbirth is a baby born with no signs of life, essentially a baby that's born dead. And so we talk about, we talk about pregnancy as a very exciting time, but not all pregnancies will have good outcomes. And I think too often we don't talk about that. We firstly assume that everyone is excited to be pregnant. And then we assume that every baby is going to come out of this journey alive. And even worse, we assume that every mother is going to come out of this alive as well. And so there's nothing worse, especially as an obstetrician, to lose both a baby and a mother, but more so for the family, because if we feel it, if we being so distant, like literally, we've only been part of your life for a very short time, how much more the family, how much more the rest of the family that has to deal with the loss. So going through an entire pregnancy, and it doesn't matter, sometimes we talk about a miscarriage happening, it's a death early in pregnancy, whereas a stillbirth is after 28 weeks of pregnancy. But for the woman who's lost their child, who's carried this pregnancy, has felt movement, has felt their physiological changes, that is a life that is lost. And so it is a very painful and stressful time. But unfortunately, also depending on the cultures that you go through, how you mourn for that varies, because for some women where people didn't know that you're pregnant in the first time, do you have a funeral? You don't have anything to bury, for example, whereas for the woman who everyone could see, there'll be a lot more compassion towards it. But, along the topic that we're talking about, this is just highlighting some of the stresses that come with pregnancy that we often don't speak about. And so from the time that you find out you are pregnant, everyone's worried, am I going to make it through this pregnancy? Will my baby come out of this pregnancy alive? But those are the things we often don't talk about. And so important that we start highlighting some of these things.
So it's this 28 weeks that then is classified as the stillbirth.
Yeah, but also to just say that definitions vary by countries. So the World Health Organization uses 28 weeks. And the definition also varies because of the resources that a country has. Not every country will have the resources to resuscitate, to ventilate a baby that's born, earlier than 28 weeks. So 28 weeks is really used perhaps to say by poorer countries, because if you go to countries with a lot more resources, they are able to do more for babies that are born prematurely. And so the definition is not a standard definition. It depends on the country that you're in.
Now, there's a lot of hormonal changes that happens in that time, right? So when you fall pregnant, if you're wanting the pregnancy, if you're lucky to fall pregnant and so forth, many employers say that women are just baby factories, and so therefore they don't want to employ them, right? That's a common assumption that happens, and so they're not going to be as productive. Anita, the issue of contraception, right, is linked to hormones. Just tell us about contraception and the similarity between what happens in contraceptive drugs, or what's similar there to hormone replacement therapy. There's elements there of similarity. Just tell us a little bit more about that.
So, I mean, if you start with contraception, there's obviously many different types of contraception. So there's differences in actually what's in the contraceptive, and there's also differences in how it's administered. So, for example, something that's very common in South Africa is the injectable contraceptive. We have the 3-month contraceptive, the 2-month contraceptive. In there, we have something called progestins, which are synthetic or mimics of progesterone, the natural hormone. It is not progesterone, it is a synthetic mimic. But even though there's a progestin in both of them, that it's not the same progestin. So you cannot assume that they will have the same contraceptive effects. So they'll prevent pregnancy, but they may be associated with different side effects. Then you have something like the pill. The pill, you either have a mini pill that also only contains a progestin, or you have a pill, a progestin that's combined with some type of estrogen. And this estrogen can also differ. And the estrogen here is then added also to help regulate the menstrual cycle. So those same components are found in menopausal hormone therapy, or hormone replacement therapy as it's more commonly known. But the dosage differs. Also, the exact progestin and the exact estrogen will differ with different formulations.
Okay, so the big scare around menopausal hormone therapy, or HRT, right, and a lot that happens with that can actually be present in the contraceptive pill or the injection. Am I making the right assumption?
Yeah, that's right. So the same compounds that's found in menopausal hormone therapy can also be found in contraception, but it's at different dosages. The dosage matters.
Okay, all right. We're going to come back to that, and I want to touch on the issues of estrogen and whether it. But Renata, just thinking about this now, right? A lot of complications. So if you want to live in this modern world, you don't want to have too many children. You may not be able to afford too many children. You may want to have children but cannot fall pregnant. There's a lot going on there in terms of mental processes. How can women better cope with that? What have you found and seen? How do women cope with it? Are we coping with it?
The first thing is that there is the societal expectation, and even the expectation that of women that they have from themselves. I shouldn't experience premenstrual symptoms. I shouldn't experience postpartum depression. I shouldn't be hormonal when I hit menopause. That is nonsense. I mean, that is how we made biologically. And I think if we can empower ourselves with understanding it better, it's easier to manage. Even with hormone supplements, when you do infertility treatment, we know that there's side effects. But if you can cognitively prepare yourself and you know what is the side effects to expect, you can deal better with it. The one thing when I just heard is estrogen always makes me smile. Not literally, but like it's so important for women. When estrogen plummets, our serotonin plummets. So estrogen is what we call also a cofactor in the production of serotonin. So that's why we have hormonal fluctuations, our mood changes. So how can't it change? It's a biological thing. So also when people go through menopause, the estrogen that really, really drops, it's not the fact that once your estrogen is low, it's almost like okay to cope with it. It's the roller coaster that's really difficult. And we also know that women is very, very susceptible for depression and anxiety around menopause for that reason that the estrogen is dropping, and we often need to change antidepressants because that works pre-menopausal doesn't necessarily work post-menopausal. But once again, it's not supposed to be a train smash because we have brilliant research, we have brilliant medication, and to know what is the difference between normal experiences that I have, and that's why a mood diary, even when we're young, is maybe not a bad idea, just to track a cycle to understand, okay, 3 days before the time I feel like this, that it's not necessarily the end of the world, but if it is significant, if it affects your functioning, whether it's premenstrual symptoms, then we call it premenstrual dysphoric disorder, whether it is just normal postpartum blues, or whether it is natal depression, which is very, very important to screen for. Also, especially at 6 weeks after birth, the mum and the baby need the significant proper evaluation. It can be treated. And then also around menopause. It's interesting, a while ago, I'm a late mom with all the stuff that you've talked about now. So went through all of those. And at one stage, I went to a gynae to ask, is it possible to breastfeed in menopause? Because my hormones was just so dear makar. And then it was interesting to also understand that we minimize some of the symptoms that we experience in the perimenopausal period, the brain fog that we have, the poor sleep that we have. And we think it's all kinds of stress. We think it's just the little one waking you up. But there is actually biological changes, and we need to be more informed. And I think my message is always, when it comes to mental health, or even the discussion today, is information is power, because then we can do something about it.
So absolutely I know the brain fog that happened straight after birth, and I know the brain fog during menopause, right? So there's brain fog there. Salome, just tell me a little bit about this journey. If you sort of take from a young woman being in puberty, let's say up to menopause, what is the hormonal journey that we're on?
So, I mean, I think the best time in your life is before you're 8 years old, because afterwards you're on this roller coaster and it gets worse and worse. And when you think you're done at like in your mid 40s, apparently it gets even worse. But I mean, as we know, puberty starts, just before you go into your teenagehood. Of course, some may experience it a bit earlier. But yeah, I think as many of you will know, the teens, we call it probably the worst years, where they are dealing with all of the hormonal changes, starting to have their periods, starting to have their breasts grow, and all of those changes. And of course, there are those who will experience all of these things and not know what to do with it, because we can talk about the physiological changes, but I'm always interested in what does this mean for the individual? What does it mean for that society, for that community? When you have your first period, are girls socialized to go and explain to their mothers? Do mothers know what to say to them? And how do you deal through that entire journey? But as we know, so there might be a number of girls may experience irregular periods as they start going into, the phase, and some are not sure, is this normal, isn't this normal? But then we start hitting the reproductive years, and as I said, it gets worse. I think for and when you start, I think fertility, before it's the contraception. So before you get yourself into the surge with your natural hormones through pregnancy, it's first for many women will be going on to contraception, which also comes with a lot of side effects. And, like you're saying, try these things out and see what works for you. We can prescribe and tell you that, you may have weight gain, you may have this, but it differs for everyone, and try it for a short time and see if this one works for you or not. And if it doesn't, it's okay to try something different and until you find something that you think is good for you physiologically. We don't talk often about the mental health effects and the mood swings that may come with some of the contraceptives that we take. And also for women who might be, perhaps you're in your early 20s, you are wanting to have children sooner. Should you be on a long acting, short acting? And those are the kind of things that you should always inform yourself about and find out from your gynae, read about it and know what's the right contraception for you. But as you go into pregnancy, the body is producing more hormones to protect your pregnancy. Because for the body has to, the priority at that time is your pregnancy. This baby needs to grow. You have a surge in your progesterone, etc. And at that time, that can also come with a lot of negative moods and mood swings, and all of that can also bring down some of the negative emotions so you wonder why pregnant women may be highly emotional, why you may find yourself crying when you hadn't planned, when you're not really having a bad day but you're really feeling excessively emotional. And then after the delivery you have to go through another swing again. So all I'm trying to say is your body has its own hormonal cycle, and inform yourself, learn about it, understand what's going on, but also it changes with time, and then there's menopause. And so I think empowering yourself by understanding these different cycles and periods in your time, in your life is important, but also finding what else can I do? There are times where you need more emotional support, a life coach, a psychologist, all of those things. And so it's not for us to sit at home and suffer on our own. And also, if you're on a medication or a hormonal drug that isn't taking the best out of you, it's also okay to stop and look for something that will work better for you. And so we don't have to be prisoners, basically, of these hormones that are in our bodies.
And I mean that, and Donita, I want to touch on that, because what often is said is women are too emotional. So let's not have them in the workplace, because they are just incredibly emotional. And how do we deal with these mood swings and things like that? So Donita, just coming back to this idea of progesterone and progestins and so forth, in terms of menopausal hormone therapy, what is it that women need to know about the compounds inside some of these drugs that we are able to take? And the big question, and this is why it was fascinating for me when I spoke to you earlier, and it's a no-brainer, but yet we don't think about it like this, is you saying, but remember, contraceptives have similar compounds in it, but yet we talk a lot about cancer during HRT, right? And the risk of breast cancer. So just talk us through progestins, the propensity perhaps to trigger cancer. What is happening there with HRT?
And I just want to quickly touch on something Salome said, which will probably lead into this. The idea that you can try one contraceptive, if it doesn't work for you, you can try another contraceptive, and so forth, until you find one that works for you. That is because they don't all contain the same thing, right? So they have different estrogens or progestins in them, and they have different concentrations or doses in them. So that is why women respond differently to the different contraceptives. In terms of hormone replacement therapy, so Why is it that people talk about cancer with hormone replacement therapy and not with contraception? Is purely because there were large clinical trials done for women on menopausal hormone therapy. And there are no such studies or very limited studies in terms of contraception. But there are studies that have looked at contraceptives and that have shown also a link to increased breast cancer risk with the contraceptive use of progestins, but more so for the HRT because there's bigger studies. There was a big study in the US, there was a big study in the UK, and also in France. And all of those showed links with progestins and breast cancer risk. But I have to add, there are many different types of progestins, many different generations. So there's the older ones that were made many years ago. Then there's the second generation because they were trying to reduce cardiovascular risks. Then there's a third generation, and then there's the newer fourth generation. So especially the fourth generation have not really been assessed in terms of breast cancer risk in large clinical trials. So the idea that we're saying HRT is bad, we should not be saying that. We should be saying what is in there. And that can only be done if you have, when you go to your GP or your gynae, to have informed discussions. But that, of course, means that your medical practitioner should also be informed, right? And keep up with scientific research. So it is not all progestins or all estrogens that are linked to increased breast cancer risk. I think that is the important thing. It's like contraceptives. We need them, right? We cannot go without them. Just the same as with menopausal hormone therapy. People use it for different reasons. So you may use it because you have hot flushes, but someone else may be using it because they actually have risk of osteoporosis or decreased bone density. Then they should be using it. So one has to weigh up the benefits and the risk profile.
Yeah, and just on the progestins, you mentioned something previously about the what is used as the base to manufacture this, right? And you mentioned some equine link. Just tell the audience a bit about that so that we can understand where do these compounds come from.
So I think I want to start by saying that the natural hormones in the female body is estrogen and progesterone. Those are mainly the sex steroids. But we also have some testosterone. In fact, estrogen is made from testosterone, just like men also have some estrogen. So one should add that. But so the equine that I was talking about, so in the contraceptives and in the hormone replacement therapy, you have synthetic estrogens. And so they come, so the conjugated equine estrogen, for example, comes from horse urine, I think it is. So that's where it is extracted from. You have others, you have estradiol, which is the most potent natural hormone in the body, but you have a synthetic one that is made. So what you have is you can have a compound that is extracted, let's say, from yams, and that is then a natural thing, but then it is synthesized to look like the natural hormone. So it has the chemical structure of the natural hormone. So it is semi-synthetic, if you want to call it that. Those are the estrogens. In terms of the progestins, natural progesterone can actually also be used in menopausal hormone therapy, but it is a mimic. So it is also made the semi-synthetic way. But that hormone is then not associated with these increased breast cancer risks.
So one really needs to read this leaflet that you get, this very long disclaimer that comes with it.
And the thing is, you don't expect everybody to know that. So you have to speak if you're in the position where you need it. No, and when do you need it, people say? Because some people go without it. It is when it affects your quality of life. So if your quality of life is affected, speak to your medical practitioner and ask the questions. If you have a family history of breast cancer, speak to them and speak to them about your concerns. They should be able to steer you in choosing the right therapy.
Therapy. Renata, just thinking about this and the fact that people say that women may become more depressive or have tendency to rest and deal with stress differently. Perhaps we just vocalize also. You know, you spoke about it. We seek help in a different way, so it's more known than perhaps men. Can you combine, let's say, antidepressants with HRT or with contraception, the contraceptive pill? And how do you go about actually doing that? Because, like, when are you over medicating, and when is it okay to combine?
It's absolutely always okay to combine. It's two different systems in your body. I mean, like, I'm not going to, if your car gives problems, we're not going to just work on the engine and ignore the tires. We know we're going to work on both. And I think that is this synergy here. You have always to look after your physical and your mental health. And if we do not look after the biology, we can get patients that really do not respond to the antidepressants because they have low estrogen, or the thyroid doesn't work, or their iron is low. We need to check that. However, there is also interaction. Sometimes someone is really, really stable on the antidepressants, and we add a new contraceptive, and it can rock the boat a little bit. And that's where I would recommend a time period of 3 months before you change hormones then, and keep a mood diary. Also, when we have younger patients, adolescents that go onto hormone replacement therapy, they really can battle initially to find the right one. And once again, keeping a mood diary can give us a good indication what has happened when. When do you take the active tablets, the inactive tablets? Have you actually been taking them? Because that's also sometimes, I always say, if someone doesn't respond to their treatment, the first thing you ask is, are they actually taking it? The second thing, do you have the right diagnosis? And then you start to make changes. But yes, I think combination of the two is safe. But once again, you need to monitor symptoms, you need to diarize, you need to check, because the one isn't the other. Often what I see is patients start to complain that they have hot flushes on some of the antidepressants, and some of the antidepressants can make you feel warmer. But depression can make you feel warmer because it affects your temperature regulation. Then the wrong room temperature can affect it. But then they might also have an iron deficiency that make the hot flushes worse, or they might be perimenopausal that give them hot flushes. So it's not always as simple, and a proper history is important. And also to communicate with our fellow specialists. I don't think GP, psychiatrists, gynaes, anyone should work in isolation. Pick up the phone and let's discuss the patient.
Yeah, and have these sessions. I want to come back to the issue of perimenopause and menopause. What is this? Is there in fact something like that? Does it exist? Salome, do you want to weigh in, or Donita? Yeah.
I mean, Perry is obviously talking about that phase where where you're starting to have menopausal symptoms, but you're not fully menopausal. So you might have hot flashes. That's where you're asking yourself, what's going on with me? What's going on with my body? Your periods start getting irregular, or you start seeing less and less, and then suddenly it appears when you're not expecting it to appear. So that can be a very, I think, daunting time for some women as well, because you're trying to understand, is this it, or not? But then once you're really into that menopausal phase, and the decisions that need to be made in terms of, HRT and whatnot. So I think it is a phase. You don't just wake up and suddenly, okay, now I'm in menopause. You go through a few months or longer, for some women it's even longer, but you go through that place, and it's through phases and stages. And so as you go through the different stages, perhaps, you can talk about the hormonal side alongside that.
So I'm going to say by definition. So you have your premenopausal state, which is when you have your regular period. And this also differs in age, but mostly it is considered, I think, up to about 35 years old. And then you could, at that stage, start going into perimenopause. Now, why do you go into perimenopause? Is because your estrogen levels now start dropping. So they decrease and they decrease and they decrease. And this is why you have this irregular period and mood swings and all symptoms of the menopause. Menopause is when you then stop having a period. And if you have not had a period for 12 months, which is a year, then you are said to be postmenopausal. So your level of estrogen at menopause and postmenopause, it plateaus very, very low, but it's there. So you don't have zero estrogen. You will still have estrogen, it's just very, very low.
And brain fog, I want to come back because and I want to ask you about this, Renata. So this brain fog thing that happens, I don't know, some of you in the audience would know about the brain fog, right? So what is that? What happens to you when you have this brain fog? And I mean, like a few weeks ago, you're bright as a button, and then all of a sudden you have this brain fog. So what is that?
I can't recall the definition now. I think the interesting thing is it's really you feel doof. You don't get the words. It's sort of like the stupidest things that you could usually juggle, that you drop the balls. Like you have to walk back to see, did I switch on the washing machine or not? Or you put the button in the microwave, and all those simple things that happen. And at work, it's just like really small things that you usually wouldn't have needed to write down that then slip your mind. So you really feel that you have a little bit of a cognitive decline. The problem is, yes, it can be hormonal. The problem is it can be due to disruptive sleep, whether you have a baby at my old perimenopausal age, or whatever the case might be, but just sleep deprivation. And there's so many factors that cause sleep deprivation. It can be hormonal, it can be iron deficiency, it can be ambient reasons, it can be family, it can be stress. So now we already sit now, is this brain fog due to hormones? Is it brain fog due to sleep deprivation? Is it brain fog due to anxiety or depression? So because we all cluster it as brain fog. And now even more people talk about the brain fog in post-COVID or long COVID. So what exactly is it? So brain fog is not a definition. There is really no such thing. It's an experience that we have of cobwebs in our head. And it can be due to many, many different reasons. But is the brain fog real? Absolutely. And many of you would have experienced it, even some of the men. It's not, remember, men also have hormonal changes. They also have their andropause. So they can also experience a lot of what women experience, which is maybe less talked about even. And not as regularly. You don't have the monthly difficulties that we have, but definitely the andropause. And we also see that is a sensitive period for men. And I often think, although we have Women's Months, we mustn't ignore the men. And there's many of you in the audience as well.
Yeah, no, and absolutely. I mean, we're all hormonal beings, right? So this is how we function and what we forget often, right? Especially if we look at workplace type behavior, is what is going on with this person? Why is this person reacting in this particular way? What is it that they need? Perhaps that is slightly different.
Something that I feel quite strong about is that it sometimes become almost permissive in workplaces to blame women for being a woman. So when you're younger, before you have kids, or even if you couldn't have kids and there's infertility or whatever the reason is, or you choose not to have kids, if you do well, it's, oh yeah, but it's because you don't have children. Once you have children, if you have a bad day, or if you are late for work, or if your nanny don't arrive, or whatever the case might be, oh, but we can't ask her because she's a mother. I mean, like, why is it that we often in the workplace, women are being punished just for being a woman by other women?
Yeah, no, absolutely. That and it's again the social issue that, you know, how we socialized, how we think about things, you know, how we consider people's performance and so forth. All of those things blend in. The psychological and socialization blends in with the hormonal, and then we don't know, you know, after a while, what it is that's happening. Absolutely, to that point, Renata. can breast cancer survivors use HRT? That advisable or not? Is this something that should happen or should be avoided? Anybody? Yeah, there's Renata, and then I'll move there.
It's not my specialty, but I have a family history of breast cancer. So we have been well read up on it. And my husband is a pathologist, so I often ask him as well. And it has to do if you have hormone sensitive type of breast cancer or not. So when you have breast cancer, they actually can test for receptors if hormones is going to affect this type of cancer or not. So it's not a blanket statement, no. We are more hesitant and we are more scared, but it's not a blanket statement, no. As far as I understand, the oncologist can test actually if it is a hormone sensitive tumor or not.
Hey, thank you for that, Salome.
So agreed fully that it has to be individualized. And I think the other, what we haven't spoken about today is issues of access. We're speaking about hormones, HRT, contraceptions, as if anyone in the world can get them when they need them. But in reality, there's an unmet need for contraception, especially in Africa. There's an unmet need for HRT, especially in Africa, even worse, with HRT. So we also need to think about the socioeconomic factors with all of this. But definitely for every woman, it needs to be individualized. And I think there is no blanket statement around whether or not it should be used. Yeah.
I should maybe say that Renata hit on something that's very relevant, and that is when we talk about breast cancer, we talk about it as if it's one thing. There's many different types of breast cancer. So you have the one that is hormone sensitive, and in fact, most of breast cancers are hormone sensitive, about 70%. And those are the ones that are linked to the hormone therapy and the contraceptive. The triple negative breast cancer that does not have these receptors, those are not linked to the breast cancer. Should women be using it? So the South African Menopausal Society actually has a guideline. And I think in there it says that if you have had breast cancer, if you currently have breast cancer, and if you have a family history of breast cancer, this is of course now the hormone sensitive one, that you should preferably not use certain menopausal hormone therapy formulations.
Yes.
But it's also then important there from a mental health perspective, many of the treatments for the hormone sensitive tumors, when they give the hormone blockers basically, can cause depression because it blocks then the hormones, so you can produce less serotonin and it triggers depression. So once again, very important for us to work with the oncologist in managing the patients and even maybe add an antidepressant before they start to use the hormone blockers, because if you're depressed, your outcome of cancer is in any case also worse.
So just on the treatment for hormone sensitive breast cancer, so the treatments are blocking the production of estrogen, and blocking the activity of estrogen. So there are two ways. And with that, of course, what you're doing is you're putting women, young women often, into menopause. Okay. So that is why they experience similar symptoms as women in menopause.
I just also want to understand, if we go into menopause and our estrogen dips, does it start dipping and that it continues to plummet? Surely we need estrogen. So there's a lot of misconceptions about being in menopause and estrogen dipping, and then what happens after? Is this like an onward game of downward spiral? A lot of people talk about dementia then that kicks in and so forth, and whether that's related, I'm not sure. Salome, does it dip? And what happens to it after that? In other words, what is the journey after menopause, hormonally speaking?
I mean, you almost, I guess, in a way, go into this plateau phase, and you're not going to have your estrogen levels that you previously had in your earlier life again. And of course, that comes with other exposure to other conditions and all of that, and other things that you might experience, and other, for example, for the older women, we want to prevent things like osteoporosis. We want to prevent other things from happening as well. So it is, again, about understanding the different stages and phases and kind of adapting and remodeling yourself and your lifestyle. Talk about supplements, for example, as we know, like during pregnancy, there are certain supplements that you want to take when you're older. So apart from the hormones themselves, there are also other things as well that you can take to keep yourself healthy as well. So I think just really understanding the phase, the cycle, your family history as well, and some of the things that you might be more predisposed to that perhaps other people may not necessarily be. So I think it's just trying to understand the entire, understanding yourself and your body at that time.
And rather using natural products. And I'm asking Donita this specifically because this is something that you have, please tell us about your opinion about natural products.
What is a natural product? I'm not an expert on this, but so when the first results of the first clinical trial in the US was released, there was huge confusion and alarm because of this increased breast cancer risk, and this of course caused women to stop using the normal FDA approved drugs. So they went to something called bioidentical hormones. I don't know, Salome, if you've got a lot of experience with this.
No, I don't.
And it was interesting. So these are made by what is called compounding pharmacies, and they make personalized medicine. But these drugs are, and they call them natural, but these are what I would say semi-synthetic, because yes, they extract a certain compound from a natural product, but then they chemically manipulate it to make a compound into progesterone or estrogen, which means now it is semi-synthetic. In addition to this, there is no clinical studies to show that there's actually benefit or more benefit to using these bioidentical hormones than using the normal FDA-approved medication. And I met with alarmingly, I met with a GP many years ago that wanted to know more about bioidentical hormones. And she was saying, no, she just gets these made by someone in a garage. And that was really shocking. But that was the extreme that people would go to want to get something natural. If there is something natural, I guess a colleague of mine, which I think is online, did some research on cyclopia, the honeybush tea, which contains phytoestrogens, which basically means it contains compounds that comes from a plant and that can work like estrogen. But these were, so estrogen works via two receptors, and the one receptor is considered bad in terms of breast cancer, and the other one is considered good. So these phytoestrogens do not have the bad effects via the bad receptor, but it has the good effects via the other receptor. So this is said to be a possibility for menopause. The question, of course, is how much tea do you drink? I don't know.
Like I have a permanent pot of honeybush tea next to you. I can see everybody starting to do that. St. John's wort, right? So tell us again, because a lot of us want to go and buy at shops, all of these other preparations because they're better for our body.
So even I often get people, can't I use the natural ones? And I've done quite a bit of work on it. But for example, St. John's wort, 5-HTP, so that's it's like a tryptophan. It's a precursor of serotonin, usually what we need in food. But 5-HTP, what is in John's wort, is basically then this natural serotonin. So you take something that was manufactured or semi-manufactured, semi-synthetic, and you take it. Where most of the antidepressants is reuptake inhibitors, which that means is the serotonin that your body produces naturally, we block the breakdown. We don't give you anything synthetic. We just make what is in your body work better. Most antidepressants work that way. We do have other types of antidepressants as well. So people often think that what they can buy over the counter is more natural than registered medication. The only reason it's over the counter is because the studies has not been done to be able to register it as safe and efficacious to use. Because if the studies was done for a specific indication, it would have been a registered drug. So some of the things that you can buy over the counter have way more side effects and way more risks. And I'm even appalled at how easy it is that moms give over the counter complementary and alternative natural products to their children. But then when we go and read up on the ingredients, so one classical example, Bacopa monnieri, that moms like to use for ADHD, for example, for their children, there's 2 strains. The one that you can commonly buy over the counter can cause infertility. It's great if you have an infertile teenage boy, you will have less unwanted pregnancies, but gosh, you will be sued if he's an adult and he struggles to be fertile. So we often make that mistake. Secondly, patients, what is difficult for us is we have prescription medication, we know what we expect, how it works, what is the safety profile, what dose to use, and then you put a natural product with, and there's potentially dangerous interactions. So, for example, any psychiatric medicine, guarana, ginseng, ginkgo biloba, you should not combine. Some of it can cause interactions that can put you in a coma. So it's not necessarily safe to use over-the-counter medication or camis, and you always, always, always should disclose it to your healthcare practitioner as well, because we should be abreast with the interactions and what is dangerous and not. So I would always, if you want to take something natural, even then ask for advice, not from TikTok, not from the Facebook group of the mamas of the whatever suburb. You ask as a registered healthcare professional.
Thank you. And with that, I want to open the questions to the floor. Any questions online? If you can please help us with those, that we can hear the questions online.
So the first question was, which contraceptive would you recommend for a first-time young person?
Right. Salome.
Yeah, so you know what I always shy away from is having a medical consult, a group consult like this, because there's so many things you want to know about the individual before you recommend which contraceptive they should go on. And I think what she was explaining at the beginning, that you know they are very different. You know, it's the different doses and all of that, and formulations. And so I think we don't give blanket, like, how old are you? You know, what's your past medical history? We want to know all of that before we recommend a specific contraception. So that would be my answer for
So go to a healthcare professional, right, and get professional advice on that would be the answer.
Second question was, do bioidentical hormones have less health risks than synthetic hormones?
Right. Donita.
So I'm going to say that there is no clinical evidence to suggest that bioidentical hormones are better. And myself, we did a study just at the cellular level looking at bioidenticals and comparing it to estrogens that are used in hormone therapy, and we saw no difference between the two. So I don't see at this point any advantage to taking bioidentical hormones.
One more question was, what are the main differences between natural menopause versus surgical induced menopause, and for how long should you then use the HRTs?
The differences, yeah, but natural menopause versus surgically induced, medically induced.
So, for example, with natural menopause is natural. Your body goes through the physiological changes. But for example, if you have to have a hysterectomy for whatever reason, and your ovaries are removed at the time, then that takes you into surgical menopause, because the production and the release of those hormones that would have naturally continued has now been cut off. And so those women need to be supported, counseled beforehand that these are the changes that you are going to experience. And because they don't go through that natural journey where, things stop one at a time, but now are going through, those symptoms all happening at the same time. And so again, you work together with your gynae, with your multidisciplinary team on how best to go through that transition for women that would have to have some of these changes or surgical procedures, especially if it's much earlier in life from the time that they would have experienced natural menopause.
There's a follow-up to that question. Do the hormones stabilize once menopause is over, and what do you recommend to take for brain fog?
Right, do hormones stabilize? Renata, can we hear from you, just your opinion, because it's also brain fog?
My understanding is that once you're in menopause, the hormones are stable, it's just very, very low. And hormone replacement therapy doesn't have to be permanent. Like in any medication, we treat something until there's no functional impairment, and if there's what we call remission. So from a hormonal perspective as well, when it's stabilized, when you are used to it, and your body has adapted to the changes, and when you do not experience symptoms that cause impairment, you can stop hormone replacement. I knew very few women in my practice and in my personal life that used hormone replacement ongoing, but it depends on the age, obviously. But it can be 5 years, it can be 15 or 25 years. We cannot generalize. And I think this is not the platform, as Salome also highlighted, to give specific medical advice. The same with brain fog. As I mentioned, it's an umbrella term. There's so many different things that can cause brain fog, and we need to find what is the cause for it, and then we will treat that. We also must remember that it's not always about taking something to address something. Sometimes it's really lifestyle changes, making sure about your sleep, making sure that you exercise, making sure that you not dumb your brain by doom scrolling, but rather feed your brain by positive things, building puzzles, board games, Sudoku, crossword puzzles, reading, studying, instead of wasting your time with doom scrolling. So there's many things that we can do, which doesn't necessarily mean a quick fix of swallowing a pill.
Any more questions online? And then there are questions. Can I take a few questions here, please, ma'am?
I don't know if it's too focused on depression, but psilocybin, there's a lot of research. I would like.
Psilocybin is illegal in South Africa, and that's all I will say.
There are a lot of claims, so that's why I'm asking.
A lot of claims. There is absolutely not enough research. There is clinical trials currently registered, but there was also a reason why clinical trials was abandoned in the 1960s. There is practitioners that's practicing psilocybin-assisted therapy in South Africa. It is illegal. Their licenses can be revoked. So I cannot have an opinion. I just can say that it is illegal in South Africa. And from a clinical perspective, there is not enough evidence. And the one condition overseas where we do have some clinical indication that there might be some value in it is, for example, in certain of the trauma-related conditions.
Thank you. All right. Okay. Great. Thank you. Yeah.
The question was about psilocybin and depression in mental health. I can do 5 minutes more, then I really need to go.
All right. There's a question here, and then I'm going to come to you. If you can say the question, I'll repeat, please.
Okay. I have a question and I have an observation. First of all, I know this is a woman's morning, but you mentioned andropause. I know women normally go through perimenopause and menopause at a certain age and certain symptoms, but what do we look out for in our men with regard to andropause? When does that happen? That midlife crisis?
I don't think there's a lot of studies. So the question is about andropause. What do we look out in our men? And I must also be careful at this forum because my husband is a bit older, I can also try to understand a lot of behavior. The problem with men, it's also often complicated by the lifetime that they have. As you mentioned, is that the midlife crisis? Is it the stress that they experience because they're often at the peak of their career as well? Is it also the losses that they experience pre-retirement? So there's not a significant amount of research done. But what we do know from a clinical perspective, if we do have a middle age, and what is middle age these days, but if we have, let's say, a man above the age of 40, the old middle age, now I know it's later, that have now new onset of mental health symptoms, anxiety, depression, or fatigue, or concentration issues, I tend to do a testosterone level. And it's often low. And if we replace with testosterone, they often have significant relief.
Can I ask something in response to that? When you test for testosterone in men, then do you actually also test for estrogen or only testosterone?
We actually at this stage only test for testosterone. The nice thing, as you said, men and women have estrogen and testosterone, and I'm not the specialist here, but they also, the reason also why women have more estrogen than men is we have fat in certain parts of our bodies, and fat changes testosterone into estrogen. So often we also see men that's overweight, you will have a lower testosterone than your counterpart that have less fatty tissue. So it depends on their body profile, but I won't test the estrogen, but I will try to recommend that they slim down a bit in certain divisions.
Right. And there was a question over there. Yeah.
So I think we've touched a lot on understanding our own hormones and navigating that and how fluctuating that is with the external factors. But I think my question is, now that we go into the workplace, it can sometimes be male dominated. How do we work with males not necessarily understanding or going through this process of learning our hormones to collaborate with us in the workspace?
Right. And Salome, do you want to try that one?
Yeah, I'll talk about pregnancy, right? Because my chapter was on pregnancy, and so the effect of pregnancy on work and the effect of work on pregnancy, for example, and you go through all of these hormonal changes, pregnancy-related changes, and the only thing you want to know is like, when do I tell my boss that I'm pregnant, and what are the implications? And when do I tell my colleagues, and what are the implications? And so how do we navigate coming into work when you just want to throw up, and going through all of these things? But it's tricky because you want forums like this where we talk openly about this and where men can also learn about this. But we also live with these men in our homes, many of us, most of us. And so I think a lot of the sensitization that happens needs to also happen in public spaces, in our homes, in help, and I think some of the things, for example, with leadership, having more women in leadership also changes things a bit. So I find, for example, I'll say, we won't have the meeting from 5:30 to 6:30 because I would rather be at home at that time with the kids and with the family. Whereas I walked into spaces when I wasn't in leadership positions where this was how it was done because this time works for the men. So I think there aren't any simple answers except to say that there's a work culture ethic that we need to change and work towards, and sensitizing people around how to engage and how to create a more supportive environment for those that are going through all of these changes. Yeah.
And I just want to comment on this because Renata actually very early in the conversation said that, it's important for women to empower ourselves with knowledge. And I think that's really important. But I think what is also important is to get that same knowledge relayed to men in the workplace.
What I'm going to say now might again not be very popular amongst my female colleagues and amongst the women in the audience. Hormones is not pathology. You can't use it as an excuse. So we need to equip ourselves. We need to equip the men in our lives, whether they're at home or whether they're at work. We are all responsible to have empathy with each other, and we are responsible to equip ourselves and empower ourselves. We cannot pathologize normal living, normal behavior. You have responsibility. If you wake up today and you're irritable because it's 3 days before your cycle, understand that, and maybe you can have an expectation that everyone is not offended if you do snap a little bit today, but hell, we are adults. where our frontal lobes, we still can make a choice in how we behave then. We cannot hide behind normal biology either.
Right, thank you very much for that. Thank you, very interesting question. There's a question at the back.
Long question online. Where are we in terms of achieving period leave for women, keeping in mind that in a recent survey, 60% of South African women reported their period pain as severe? How can women advocate for themselves in the doctor's office when being told to take contraception? So often women are given the most generic kind and nobody asks the patient about their medical history.
Right. So maybe just on the answer, the aspect of, you know, getting generic help is you have to voice. You literally have to voice. I think that would be the main message here. The issue of period leave, and Renata, you've just made the statement that you've made about not pathologizing, you know, our bodily function. Any thoughts about period leave? It seems to be a wave that's coming again from the West, and that there's an opportunity for women to take 1 day period leave in a month. Thoughts on that? Right. Right, because which day would you take period leave? How does that work? But more especially the idea of taking period leave. Right, I see baffled faces. Right, please, yeah.
I don't have words.
Okay, right, over here.
So I do think there's an important place for empathy and compassion and that in the workplace, you know, for all of us. We need to, especially, you know, let's not, you know, period is not the silent P, you know, that let's not talk about this, but, you know, we can be vocal and honest about these things. I think by the time you need period leave, you probably need to see a gynae who must assess and see, is there anything else going on? You know, you might have fibroids, you might have other things that are also contributing to the severity of your symptoms. And so I would say before we advocate for period leave, perhaps we need to understand what is going on. And there are people and women that go through such severe symptoms that they cannot come to work. I mean, we're not disputing that at all, but I would be concerned about us advocating here for period, for everyone has a right to period leave.
I fully agree, and I think that is important, that if that gets to the point where you feel you need to be absent from work because of the severity of the flow or the pain, then you most likely have a condition which we call menometrorrhagia, and that's a treatable condition. But to open a can of worms, and then, yes, you know, maybe we can have empathy. There's certain times of the month that I really might want to go to work with a hot water bag. And then to have empathy with that, and maybe not to need funny looks at it or whatever the case might be. So maybe, again, the empathy part. But yeah, please, if you need medical help, that's what you need.
I want to thank the panelists for doing your work for decades so that you can answer these questions easily. And I want to recognize the effort that it's taken you to be at this point, because it takes a lot of work to answer a question very quickly and on your thinking on your feet. So thank you very much for that and for your thoughtful answers. Thank you to the audience for being here today, because without you, there's no need for events like this. And we look forward to having you at the business school and hosting you in the near future. For those of you who are able to stay a little bit longer, I'd encourage you to do that, because there is another question that if the panelists are able to, if the panelists can. I know Renata needs to leave. And then we have the session with Grounded as well, which I invite you to participate in. Thank you very much.